Welcome to this session on international developments. I'm Frances Reid and I'm Programme Director for the World Ovarian Cancer Coalition. I'll have a couple of updates and pointers at the end of today's session around access to medicines and our own World Ovarian Cancer Coalition Atlas. But we're going to spend most of this session focusing in particular on the International Cancer Benchmarking Partnership Study, often referred to as ICBP. You may or may not have heard of it, but it's been running for a significant number of years now, looking at the differences in survival between certain high-income countries for a number of cancers, including ovarian. It's a hugely complex study, but delivering a wealth of really important data. We'll place a link to some of their key publications in the chat section, so you can click on those and look at them after this session. But also, please feel free, we're live, to post any questions or comments on there as well as we go along, and I'll do my best to incorporate them into our discussion. So without further ado, I'm delighted to welcome our speakers. We have Dr. John Butler, a gynecologic oncologist from the renowned Royal Marsden Hospital in London, in England, and he has been the ICBP clinical lead for ovarian cancer throughout the study. And first up to the podium is Zalaya Simmons, who is Senior Researcher for ICBP, working through Cancer Research UK. And Zalaya, you're going to start with an overview of the study to date. Thank you.
That's right. Thank you, Frances, and thank you for having us. We're really thankful and excited to be here today. Can you move on to the next slide, John? So for those who aren't familiar with the ICBP, we are an international collaboration of partners across 7 high-income countries with representation from New Zealand, Australia, Denmark, Norway, Canada, and the UK. We were established in 2009 to deliver high-quality comparative research on cancer survival, incidence, and mortality trends across high-income countries, and also to provide an opportunity to compare data and share practices and policies that seem to be contributing to improved cancer outcomes. So I should highlight here that all of our partners have a similar spend on healthcare, have primary care-led and universal access to healthcare, and also have high-quality population-based cancer registries with representative coverage. And this criterion really just helps us ensure that our research is as comparable as possible, and that the insights we provide are relevant and actionable to all of our partners. So in terms of how we work, we bring together key cancer care policy and research personnel to focus on cancer sites which are relatively common in high-income countries. So for instance, lung, colon and rectal, and also those which are harder to treat. So ovarian, pancreatic, esophageal, stomach, and so on. Our triangulation begins with benchmarking international variation in survival, survival by stage, stage distribution, and also incidence and mortality. And to benchmark essentially means we're evaluating how countries compare in these metrics against each other. And to assess cancer care holistically, we also conduct exploratory research which explores the different contributing health system and demographic factors that might explain these differences in cancer outcomes between countries. Next slide, please, John. So our research has been divided into 3 phases since we set up in 2009. The cornerstone of the first 2 phases was the survival benchmark in 2011 and its refresh in 2019. And as mentioned before, in addition to the 2 benchmark papers, we also conduct several exploratory research modules, and together these help us understand and unpick the impacts of differences in registry and coding practices, clinical practice, and also political and health infrastructure, and how these are impacting cancer outcomes internationally. So you can see there's quite a wide range of modules that we've conducted over the years, and some of the methods that we use to conduct these analyses include surveys of patients and physicians, novel data linkage to explore patient pathways, and also key informant interviews with cancer control stakeholders. Next slide, John. Thanks. The ICBP is currently in a transition phase, during which our focus has been to try to drive forward knowledge mobilization of our findings, and also facilitate, and I think most importantly, knowledge exchange and learning amongst our partners. So, for example, we've established several ICBP networks of clinicians, academics, service leaders, and policymakers that focus on different objectives. So some of these include cancer site-specific networks, such as lung and esophageal, which explore the drivers of differences in outcomes for these particular cancer sites, and also tries to highlight case studies from ICBP countries which have seen significant improvements over the duration of the study. And we have a cancer intelligence and data infrastructure network, which aims to influence national, international cancer data intelligence systems, just to try to simplify the process of international comparisons and also answer relevant policy questions. And as the transition phase draws to a close, we're scoping priority areas for phase 3 of the ICBP, and have also commissioned some research to help build a better understanding of the impact of COVID-19 on cancer outcomes across the partnership. So with that, I'll pass over to you, John.
Great, thank you so much, and thank you for the introduction. It's a great honour to be here today. So I've been the clinical lead for the International Cancer Benchmarking Partnership since it was established 11 years ago. I'm going to give some highlights of the data and how it's relevant to ovarian cancer, but we've published over 62 papers now, so clearly there's a lot of data and information there, and really welcome any offline discussions, and hopefully we can have a chat about some of this data at the end. So I'm going to zip through some of these slides, but they'll be there for reference. So we know these studies that we do, big population-based studies comparing populations, are of great medical and political and interest to the patient. So really the international comparisons of where countries' outcomes are for cancer often hits newspaper headlines. And that was true when we published our last benchmark in September 2019, when certainly in the UK, our survival data showing the UK near the bottom of the league table was something of great media interest and political importance, but also picked up around the world in our partner countries. And these are the sorts of graphics that we create, which show the difference in survival from 1995 to 2014 across a range of cancers. And you can see the UK for most of these cancers is near the bottom. And for ovarian cancer, along with New Zealand and Ireland, we have low survival. And I'm going to go into a bit more detail about this data and what it means. It's important to note that this data is population-based net survival. So that means we're looking at all the patients within a country or region diagnosed with ovarian cancer and comparing their survival to those of the background population. So it's the excess deaths that we can attribute to cancer. If we look in a bit more detail at the ovarian cancer, we can see that there has been this increase, but some countries have really progressed faster than others. And if we look at the 5-year survival, we can see how Denmark, that had low survival alongside New Zealand and Ireland back in 1995 to 1999, is now amongst the leading nations in the world, alongside Norway and Australia, with high levels of 5-year survival. We also have the data broken down by individual jurisdictions. So we know that even within the UK, for example, we see variations with England's survival and its rate of improvement in survival actually being the greatest of anywhere across the ICBP, but also greater than the other nations, the other devolved nations. So we can look at individual populations to give us a bit more insight. And one of the things that is interesting, if you look at Ireland, for example, its survival, when we last reported in 2019, looking at survival of patients diagnosed in 2014, was back where Norway was 15 years before, so a long way to go. We also looked at cancer incidence, and we can see, broadly speaking, that is decreasing across all jurisdictions. If we look at what contributes to cancer survival, it's obviously not just one factor, it's many factors. And we've set out a series of studies to try and look at these different factors that may contribute to survival. And I'm going to go into some headline data from these. One of them was about population awareness of cancer and barriers to the healthcare system. And one where the UK stood out, remember, with low survival, is a much greater concern about wasting a doctor's time. And we know that at the moment, access to primary care is a real challenge, not only in the UK, but many countries around the world since the COVID pandemic. we looked at the behaviour of GPs. So not only do perhaps in some jurisdictions patients are more reluctant to go to their GP, but given the same clinical scenario, how would GPs behave? So we conducted an international survey of general practitioners blinded to what the problem was with a patient and gave them a typical scenario here of a 53-year-old woman with vague abdominal pains and no other significant symptoms. What would they do? Would they say there's nothing wrong, or there's probably nothing wrong, come back in 6 weeks, or we should do some more investigations or refer you to secondary care? So it's just an insight as to how, given the same clinical scenarios, GPs would behave. And we found some very interesting findings. So if we look at high performing jurisdictions, so on the x-axis here, we have the 1 year net survival. And we can see in British Columbia, Ontario, Victoria, and New South Wales, all regions with high survival at 1 year, which is a proxy for late diagnosis, about 2/3 of GPs would either do an investigation or refer, whereas in England, Northern Ireland and Wales, where survival is much lower, only 40% of GPs would do a definitive either investigation or referral. And also we found in high performing jurisdictions, they were found it much easier to get access to specialist advice. So suggesting the threshold for referral in with the same set of symptoms was much higher in low performing jurisdictions. We've also recently published a study looking at emergency presentation. So we know that up to 1/3 of patients with ovarian cancer will present to accident emergency or the emergency room. And that's either because they've had very rapidly evolving symptoms, or perhaps they've had symptoms and either haven't been able to access primary care, or there were too many barriers to getting that appointment. There were different ways of looking at emergency presentation depending on the data we had. But here, if we look on the left-hand side at England, New South Wales, Northern Ireland, and Victoria, we can see a variation in emergency presentation rate. So in England, about 35% compared to Victoria, where it's 20%. And then also, interestingly, when those patients are diagnosed as an emergency, what is their survival like? And we can see in some jurisdictions that we know perform less well, such as Northern Ireland and England, the survival is lower at 66% and 70% compared to other jurisdictions like New South Wales and Denmark and Victoria, where the survival is over 75%. So this means even those patients that tend to be the more advanced stage patients presenting to A&E, some jurisdictions are better at managing those patients, and their survival appears to be better, and whether that's the health system that can respond better. And we know Wales, that historically has poor performance, they have high rates of emergency presentation, up to 40%, alongside Scotland, and also with low survival in those patient groups. Another factor is looking at the survival compared to the emergency presentation to the non-emergency presentation. And I'm going to highlight New Zealand in this area. So New Zealand has 41% of patients presenting as an emergency, which is very high. However, the mortality of those patients is in 1 year is 40%, which is lower than other jurisdictions which have a lower percentage of emergency presentations but have higher mortality. So we know that in New Zealand, almost the emergency presentation is more of perhaps a managed access to the healthcare system, and they're better able to salvage them, as are places like Denmark. So we're talking about access to the healthcare system and potential delays to that emergency presentation, barriers in access to general practice, and referral patterns in general practice. But what about the outcomes for stage-specific survival? So if we think of stage-specific survival, this means if you have stage 3 ovarian cancer, if all the treatments were the same across the ICBP or across the world, we would expect very little variation between jurisdictions and countries stage for stage. So we looked at what variation we saw in stage. So the first thing that was of note, if we look at the stage distribution of a country like Denmark, they actually appear to have more advanced stage, so about 36% stage 4 compared to 27% stage 4 in the UK. But when we delve into this data a little bit deeper, we know in Denmark, all their suspected or possible advanced ovarian cancer patients are having PET scans. So they're probably seeing a similar population of ovarian cancer patients, but their diagnostics are perhaps more thorough. So they're picking up more occult stage 4 that wouldn't perhaps be seen on standard CT scans. And we see a similar picture in some other jurisdictions like Norway, with a high proportion of advanced ovarian cancer. So then if we look at the stage-specific survival, this is looking to answer the question about what is the survival according to that stage. So remember, if the treatments were the same across all countries, we would see similar survival. So I'm going to focus on patients with distant stage. That means stage 3 or 4 ovarian cancer. So in Norway, for example, 71% of patients have distant or advanced ovarian cancer, and their survival is 47%. But for that same group of patients in Canada, UK, New Zealand, the survival is much lower, about 10 to 15 percentage points lower. So we know this implies there is a problem with treatment of these advanced stage patients in the lower performing countries. The other thing we know is that there is a variation with survival and age. And a group of patients where the survival appears to be very low are older patients. And in a way, age is a surrogate for comorbidity. So some healthcare systems are better able to meet the problems and challenges of their older patients. So if we look at women aged 65 to 74 with advanced ovarian cancer, 52% of those women are surviving 3 years in Norway compared to only 29% in Ireland, suggesting this is something to do with treatment variation internationally. Therefore, we looked at differences in treatment and whether there was a difference in either the guidelines internationally, so we all read the same papers, are there differences in the guidelines, or are there differences perhaps in those guidelines are delivered? What we found is, broadly speaking, international guidelines are the same. However, when we looked at jurisdictions which had higher performance, when we did a survey of clinicians in those countries, we found that high performing countries such as Norway, Australia and Denmark were more likely to do primary surgery, so less neoadjuvant chemotherapy, more likely to agree with an extensive or radical surgical approach, greater access to expensive drugs, and perform lower barriers to the health system. So not problems with access to intensive care beds or imaging. Lower performing jurisdictions more likely to give neoadjuvant chemotherapy, less likely to agree with a radical surgical approach, and less access to the healthcare system. So I think I've hopefully kept to time for 15 minutes, and those are obviously just some very headline studies of a huge amount of work over the last 15 years. And I have to thank all my partners and colleagues at Cancer Research UK and across the partners in the world and our funders. So Francis, very happy to hopefully stimulate some discussion and interest.
Thank you very much, John. I think if you stop sharing your slides just for the moment, we may pop some back up if need be. It is such a complex study, and there is so much information out there. So I really would urge people, if you're interested in some of this, to go and find those papers and have a good read of them. You'll find a lot of detail in there. Thank you, John, for distilling that very succinctly. John and Zalaya really would like to know, what are the questions you would like answered by ICBP in terms of ovarian cancer, perhaps? So do think about that and let us know. Zalaya, I know you said you're in the process of scoping for phase 3. Where do you think it will go? Where do you think we'll end up with it?
So yes, we're in discussions about phase 3 and the direction at the moment, and there's so many, really could go in a million different ways. There's a lot of answered and unanswered questions and research gaps, but I think where we're starting to focus in on is one, continuing our work into looking at differences in access to optimal treatments. In particular, surgery. So we already have research underway that's going to be looking into differences in access to chemotherapy and radiotherapy across the partnership, due to some complexities around coding and classification of surgery data. In phase 2, we weren't able to take that forward, but we're really hoping to really delve into surgery and incorporate that into our access to treatment work in phase 3, which will really help with a nice triangulation of radiotherapy, chemotherapy, and surgery, looking at the combination of the combination of their use and differences in their use across the partnership, which will hopefully help to explain some of the variations we're seeing in some of the survival by stage data that John mentioned, which seems to be mostly driven by differences in treatment. We also, so in phase 2, we did quite a bit of a deep dive into differences in referral pathways across the partnership. So this is referral pathways from primary care onwards. And that definitely opened up, it kind of spurred more questions than answers. And so that's an area we want to continue to develop in terms of looking at differences in cancer care pathways. So their structure, their articulation, differences in route to diagnosis and cancer pathway timeliness. So how long it's taking for patients to progress from awareness of symptoms to ultimately starting treatment, and where the bottlenecks along the cancer pathway may be. And also looking at differences in workforce and capacity. So we've done quite a bit of work across phase 1 and 2, looking into differences in access to diagnostics. So differences in access to imaging, to blood tests, urgent referrals, and PET-CT access, for example. We looked at that in phase 2, and especially since COVID, there's been a lot of questions raised around how much these differences in pathway timeliness, in access to diagnostics, and so on and so forth, are being driven by differences in the configuration of our cancer workforces and their capacity. So I think that's going to be a big focus of ours in the next phase. Okay. Yeah.
Do you believe the ICBP is having an impact?
Let John answer that one.
Yes, hi, very much so. So if we know that in cancer policies and strategies in the partner countries, virtually all of those have referenced the ICBP work. Clearly, this has been going on now for 11 years. So the data has been very important when there was a recent select committee inquiry into cancer outcomes in the UK. It was highly referenced in that. And also a lot of the infographics that you can readily download from our website are really useful to use in presentations. And and a lot of the methodology that we've done is quite novel. So trying to examine comparisons of emergency presentation, and once we've started to do these studies, those are things which can be relevant indicators, hopefully not just across the ICBP, but for other countries in the future as well. So certainly we're doing are making impact, and I think it's trying to triangulate between what is relevant to patients at the centre, but also what the understanding and impactful for policymakers. Also, it's got to be high quality academic research. So it's really trying to get all those together. I think that always there's more to be done. But I know a lot of the great work that certainly in England, the ovarian cancer charities have supported the call for an audit, and I helped write the Chief Medical Officer's report in 2014 referencing the data and saying it's crucial to have an audit to understand where the gaps lie, where needs more support, and which bits of the pathway perhaps can be improved. So in summary, yes, but always more to be done. And this is, as Zalaya said, this is such an exciting time. We're starting to look at what questions we want to ask and answer in phase 3. So I'm passionate about ovarian cancer, so I'd be really welcome input from people on this call who listen to it later as to things that we might not have thought of that you think you would like to be answered, but also how you think they could be answered.
Okay. One of the questions that has come in has been, what are Norway doing that is so different to Ireland? And I think that's quite a good sort of taking us into the practicalities of how can we move forward and get progress in countries. What are going to be those core things?
So it is clearly, all steps of the pathway. So, I often think ovarian cancer is a surrogate for any hard to diagnose abdominal cancer. So if you're diagnosing ovarian cancer, well, you're probably diagnosing pancreatic cancer or rapidly as well. So in Norway and Denmark, they have had number one, high levels of centralization. So in Denmark, they had 40 hospitals performing ovarian cancer surgery. They reduced that down to 4. Very clear what they call cancer patient pathways, both in Norway and Denmark, or cancer patient packages. When a patient's diagnosed with ovarian cancer, these are the time points of things they need to achieve, and the hospital systems will do everything to make sure the patients achieve that. The outcomes, so the percentage of primary surgery, neoadjuvant chemotherapy, complete debulking, are highly audited, and people have to respond if they appear to be an outlier. So everything is being highly measured. There are metrics that everyone has to get on board with to follow those. So I think that whereas in Ireland, I know a huge amount of work is being done at the moment. So I think Ireland, in a way, because it's a smaller country, has the potential to move rapidly ahead. And they're brilliant colleagues I've spoken to in Ireland. So I know a lot of work is being done. I think historically, perhaps there was surgery and diagnostics delays in that. How to integrate, I think about a third of patients or more have insurance in Ireland. And so I think trying to integrate those two healthcare systems and really having perhaps, 2 or 3 major centres of surgical treatment. Because one thing that Ireland has done, which has been really interesting, is they are amongst the best in survival in esophageal cancer, because they've done huge levels of centralisation both in Northern Ireland and the Republic of Ireland in esophageal cancer treatment, which has seen their survival actually amongst the best in the ICDP.
Thank you. Am I right also in thinking Norway or Denmark have these special clinics where people with abdominal symptoms, or what you might term vague symptoms, they're not vague to the woman, but they're vague in terms of medical pinning down?
Absolutely. So this access to diagnostics. So there are 2 sort of clinic, and we're starting to establish in the NHS, are non-specific symptoms. So we know one of the best predictors of cancer is an experienced GP being concerned about a patient without there being a specific symptom. So these diagnostic clinics, but also what we call yes/no clinics. So they could say, I would like a CT scan on this patient, and just be able to quickly get access to diagnostics. But yes, the non-specific clinics, but also the ability of the system, if a patient is referred in, everything moves very quickly.
And follows on directly from it and doesn't go round and round in circles and so on. That's really interesting. John, you've been involved in the study since the very beginning. I'm going to ask, how has your thinking changed and evolved over the time from where you thought you were starting to where you are now?
Yeah,
in relation to ovarian, I think probably.
For me in ovarian cancer, so I remember when I was employed as a medical advisor to Liam Donaldson back in 2009, he said, you'll never look at healthcare the same way again. And I think that as a surgeon and academic, I used to look at these studies like ICON 7, ICON 8, and those are about very select group of patients. And for me, population data is vital, because actually it's not the patients who go to Memorial Sloan Kettering or perhaps in Marsden where I work that are most interesting, important. Actually, it's what's happening to those patients who never access cancer centres, those women whose data we've got, we know they've got ovarian cancer, but for some reason they're never having chemotherapy. So for me, it was, because I never saw those patients, I was shocked at the number of patients who appear not to have access to any treatment. So my thinking really is to double down on the importance of whole population data, that no woman's data, they kindly contribute to these national registries, that we use that data really as leverage for change. And people don't know what they don't see. So a lot of people say, I do not recognise this happening, I cannot believe it, but it is happening because they don't see it.
We're just getting a bit of audio interference there. That's it. Yeah, it's just building behind us. But I think you can turn your mic back on again now. That's a really good It's still there. Oh.
Sorry, I'm in. I'm just going to shut a window, but
Okay. I think it's a really nice demonstration. I think I love there was an article that came out quite recently which talked about the importance of cancer plans. But not only just that a country has a cancer plan, this was an ICBP one, but that it was revisited, constantly readapted, and that it had political will and funding behind it. That's really important as well, isn't it?
yeah, so we published last month a paper trying to score and evaluate cancer plans across the ICBP. So and the key things we found, and if you like, the go-to way of doing cancer is probably what Denmark did, because they had low performance like the UK in the mid-1990s, and they've transformed things, and they've had now they've had 3 cancer plans, and those cancer plans have political buy-in, support from the charities, patient groups and clinicians, but the key thing is funding and metrics which are evaluated, and then those inform the next rolling cancer plan. So say if we're in the UK, we were promised a 10-year cancer strategy by the summer, but looking at the weather at the moment, summer appears to have passed.
Certainly has. Zalaya, what do you think can be the role of, say, our partner organisations who are largely ovarian or gynae cancer groups, often advocacy based? What role do they have, do you think, in helping get this work of ICBP really understood and get some of those ideas out there?
So I think, especially given that we're currently scoping for phase 3, looking at where we can go next, where the research gaps are. Obviously, there's a lot of more general research themes that are applicable to all of our cancer sites. So looking at health infrastructure, the way services are delivered and how patients can access them, and so on and so forth. But there's also a lot of more specific considerations, or cancer site specific rather considerations. And so I think one way that partner organizations could be of huge help is, as John mentioned, contributing or reaching out to us with questions that they might have, the research gaps that they think are priority areas and should be addressed specifically in relation to ovarian cancer, although I know that John's really keen for perhaps cervical cancer to come into the mix at some point, so maybe that would be expanded in the future. But I think that would be, in terms of helping us to inform our strategy moving forward and our contribution to the evidence base in relation to gynecological cancers, then that would be really, really important. And this is the perfect moment for that, as we're in this transition phase and kind of taking a moment to pause and reflect on where we go next. What do people really need to know? What's going to make the biggest difference?
Okay, and a final tricky one for John. I think it's been very clear so far, there is no silver bullet. There's no one thing that we can all pursue, with gusto to make the biggest difference. But where would you start if you were looking at a country's performance in terms of ovarian cancer survival? Where would you begin?
So I would say robust population level clinical audit. I think the only way I know I'm getting fatter is if I weigh myself, and it's only by measuring and seeing what is happening that we can improve things, and making sure no woman is kind of lost. So I would say I would do audit, because I think that when you've got high quality audit that is reported, people's the performance of a healthcare system tends to improve. And it's without that population based audit level data, I think that you don't know what's making a difference. And I think simply by reporting things, people can see my word, how come they're giving so much chemotherapy and no one's having surgery in this part of the country?
Thank you. That's a really strong, positive answer. And I look forward to following the work of ICBP going forward and staying in touch with you. Thank you, Dr. John Butler and Zalaya Simmons. And that's about it for today's sessions. I'm just going to briefly mention a couple of things on the international front. that you may or may not be aware of. Firstly, the Access to Oncology Medicines Coalition, the ATOM Coalition, which is led by UICC, the Union for International Cancer Control. They have launched recently, and it's an initiative working in low and lower middle income countries to improve the availability and affordability of cancer medicines, those listed on the WHO Essential Medicines list, which include all the core traditional basic treatments for ovarian cancer. So this initiative has an important role to play in low and low middle income countries to improve access to those drugs. So take a look. The website is going to be linked to on the chat, so I hope you can see it there, but if not, look through the UICC portal. And the other thing is just to say we're finishing work on our World Ovarian Cancer Coalition Atlas, which will be the 3rd edition. We sort of bring it out every 2 years, and it will include a whole summary of the latest thinking about ovarian cancer, from global statistics, from survival and survival differences between the countries. So yes, we refer to ICBP in there and pick up on some of the things it's bringing forward, and some of the other studies like Concord and so on. So that'll be coming out early in the new year, so keep an eye out for it. I know a number of you use it quite specifically to help prepare for submissions or advocacy work and so on. So that's it for today. We will be back tomorrow at 2 p.m. UTC GMT. We'll be starting with a really interesting session on innovation and technology in cancer research. Then a session where a number of partner organisations are going to share their expertise on key topics, everything from, doing a strategic review, those sort of things. I'll be giving an update on the Every Woman Study Low and Middle Income edition, and we'll be announcing our plans for World Ovarian Cancer Day 2023. The clock starts here ticking, and we already will be pointing you towards resources that we can provide you with as you work towards May the 8th next year. And then finally, we will have a celebration of our Impact Awards. You can hear all about the amazing work of some of our members, partner members, and individuals as they work like we do and you do to make a difference for women with ovarian cancer wherever they are in the world. So I'm Frances Reid. Thank you for being with us. And on behalf of the Coalition, we do hope you'll join us tomorrow. Thank you.